Obviously, with any surgical option, there are always complications to consider and watch out for. For these bariatric procedures, which complications tend to be the most common, would you say?
So, as with any surgical interventions, the kind of perioperative or short-term complications can include risk of bleeding, risk of infection, risk of thromboembolic events such as DVTs and PEs. That's something we worry about significantly, especially in this patient cohort, and we take several steps to minimize them, including administration of perioperative subcutaneous heparin, early mobilization, and pneumoboot compressions. But probably the risk that most surgeons worry the most about when doing a gastric bypass or a sleeve gastrectomy is a leak from the staple line. So, in case of a sleeve gastrectomy, that obviously you have a long staple line that the leak can occur. And in case of the gastric bypass, the leaks that tend to occur at the gastrojejunal anastomosis because you're bringing a loop of small bowel up to the stomach. The anastomosis can sometimes be under a little bit of tension. Obviously, the blood supply is not as good. So the leaks, when they occur, they tend to be in this area, although there is still a small risk of getting leaks at the jejunal anastomosis further down.
So, for example, then, if it's suspected that a patient has leaked post gastric bypass, which tests or investigations might be appropriate in this circumstance, and how might it be determined whether a conservative or a surgical approach should be adopted in order to manage the patient?
Sure. So I think detecting a leak after a gastric bypass can be actually notoriously difficult. So although sometimes patients present with typical symptoms of, fevers, leukocytosis, tachycardia, and upper abdominal pain, sometimes the symptoms can be more vague. And in general, as a clinician and a surgeon, it's important to have a high suspicion for a leak. So even if sometimes patients present with shortness of breath, this differential should come to your mind. The tests that are ordered is usually, obviously, we start with some baseline blood values, check a CBC and see what the white count is.
That's a full blood count in England.
Yeah, full blood count, exactly. See what the white blood cell count is. And in terms of imaging, you could certainly start with an upper GI. However, an upper GI doesn't always detect all the leaks.
And sorry, just to avoid any confusion, an upper GI in the US is the equivalent of what in the UK?
Is like an X-ray, a barium swallow.
Okay, barium swallow.
Barium swallow. Although you won't use barium, you'll use a gastrographin, so it'll be a gastrographin swallow.
Okay.
If sometimes patients, you could have that. The other test you could do is a CT scan with oral contrast. You give patients a small amount of gastrographin, get a CT, and look for evidence of extravasation. But I think in general you should have a high suspicion, and if the imaging is negative but the patient is clinically shows signs of sepsis and you're worried about a leak, a lot of people just take them back to the operating room and explore them laparoscopically.
Okay, great, thank you. And finally then, what kind of follow-up do these patients get? For example, how often would you expect to see them in clinic? Are there any other members of the MDT, like a bariatric nurse specialist or dietitian, etc., who are involved within the ongoing care of these patients?
Sure, great question. So patients are seen in the perioperative period, usually 2 and 6 weeks after surgery. Purpose of that from a surgical standpoint, obviously, to make sure the wounds have healed well and they're doing well and no evidence of any surgical complications. During this time, they're also seen by their dietitians, and in fact, I think those visits are probably most critical to the patient because during this phase after surgery, they progress their diet. So they go home on a liquid-only diet for 2 weeks, and after that, they advance to a soft diet, and after 4 weeks after that, they start slowly progressing diet to a more diverse consistency and also contents. So the dietary and the dietitian visit during this time period is very important. During the first year, in general, the patients are seen every 3 months. In the second year, they're seen every 6 months. And after that, we like to see our patients annually. And during these visits, what we do is we check their blood tests and blood values to rule out any evidence of nutritional deficiencies. And we monitor their weight loss. We assess their comorbid status and make sure that the diabetes or the hypertension has resolved. And they continue to see the dietitian during these visits regularly. And the regular follow-up is really important because not only it helps us make sure that nutritionally they're doing well, we also try to identify problems early, and we can be proactive rather than reactive to adverse situations that may be coming. And there's also some suggestion that patients who follow up regularly, they tend to do better, and risks of weight regain or inadequate weight loss tends to be less. I think I talked about this earlier, but during follow-up we also have psychologists available, and we in fact encourage them to see them once or twice during the first year to provide any assistance that they need with lifestyle changes.
Okay, so they have a lot of support kind of pre, during and post-surgery then.
And I think another source of support that should be highlighted is other patients. Okay, so we in fact either have support groups where patients come in and they meet and interact with other patients in a similar stage of recovery, and they share stories and challenges, and a lot of patients find that really extremely helpful.
Oh, that's great. Well, thank you so much for speaking to us today.
Not at all. Pleasure.
Thank you. Cheers.
Thank you.
Thank you for listening to another podcast brought to you by School of Surgery. Remember, you can follow us on Facebook at School of Surgery, on iTunes, on Podomatic at schoolofsurgery.podomatic.com, and finally by searching School of Surgery on YouTube. Thank you very much, and see you next time.